Good afternoon, all. A very
Good
warm
afternoon, Dr.
welcome
Joshi.
for our Academics with Institutions. Today is our 13th episode. We are back with the medical college, a renowned medical college from East Zone, that is Assam Medical College from Dibrugarh. Hearty welcome to our Honorable National President, Dr. G.V. Basavaraj sir. Thank you so much for joining in spite of your busy schedule. A hearty welcome to our HSG, Dr. Yogesh Parikh sir, welcome. And our Vice President, Dr. Santanadev sir, hearty welcome. Dr. Satish Sharma sir, our past President, Dr. Pramod Jog sir, and all the faculty from Assam Medical College and all the dignitaries here and all the viewers. I would now request our HSG, Dr. Yogesh Parikh sir, to deliver the welcome address.
Thank you, dear Dr. Priya Madam, for the conducting very well program. This is the 13th episode of the academic through with the institutes, and latest from the Central IP, the officials, we give the congratulations message to Dr. Jagdish Chinnappa sir for his birthday today, and he is with us as an advisor. So I welcome our President, Dr. G. Basavaraj sir, Dr. Vasant Kalatkar, Dr. Upendra Kinjadkar, Dr. Atanu Bhadra, and Program Coordinator Priyaji, Jagdish sir, Dr. Shantanu Dev, Dr. Kalpana Madam, and our Chief Guest, Dr. Gnanendra sir, and Assam Medical College, Dibrugarh faculty, Dr. Aarti Dekha Madam, Dr. Rita Bora Madam, and Dr. Arpita Gog Madam, and all the PG students and the faculties. So this is the 13th episodes, and very well appreciated across the country, and the maximum presence in this academic program. And we are involving the medical college faculties through this program, and from the all the premier institutes from the East Zone. So this is the East Zone, and our Dr. Shantanu Dev and Dr. Kalpana Madam have taken very care for this Assam Medical College, and they are presenting today. So thank you very much, dear Dr. Priya. Please carry on. I am in the meeting at the Mahatma Gandhi Mandir at Gandhi Nagar. So please carry on. I am hand over to you. Thank you.
Thank you. Thank you so much, sir, for being here. I would now request our National President, Honorable Dr. G.V. Basavaraj sir, to give his remarks.
Yeah, good afternoon to all. Thank you, Dr. Priya, for organizing an excellent program, academics through the institution. This is one of the most popular program across the India. Where when I getting a feedback from the majority of the medical college, every Friday afternoon they made it as one of the prestigious program where the majority of the postgraduate, house surgeons, faculties assemble in a room with a well-structured IT things. They're discussing through these things. That's one of the great initiative of an Indian Academy of Pediatrics. Thanks to our chief advisor, Dr. Jagdish Chinnappa sir. Today it is in birthday. It's almost like a birthday gift to it. And today's institution is one of the oldest medical college in India, that is Assam Medical College, Dibrugarh, is a well-known when we whenever we write postgraduate NEET examination, that's the time we used to see the Dibrugarh is one of the medical college used to be there. So we can all the institutional heads are looking at the work which is being done at the Assam Medical College. Thanks to Rita Bora Madam, is a professor and head of the Department of Medical College, taking the institution to the greater heights, with a chairperson Aarti Dekha Madam. And of course, our dynamic secretary, Dr. Yogesh Parikh, is guiding the things, along with our East Zone Vice President, Dr. Santanu Dev, is excellent coordination among all the medical colleges, not only the East and across. Our East Zone Coordinator, Professor Kalpana Datta Madam. Of course, this is all possible with the National Treasurer, Dr. Atanu Bhadra, is always working behind the scene to take the academics to the greater heights. Thank you, Dr. Atanu Bhadra ji. And of course, with the guidance of Dr. Vasant Kalatkar and Upendra ji. So without taking much time, wish you all the best for this program. I recognize the presence of Professor Pramod Jog, our past president, and Chief Election Commissioner, Dr. Ravi Shankar is also there, and our Senior Vice President, Dr. Satish Sharma-ji, Dr. Singaruvel, Professor Singaruvel, Arup Da is also there. So wish you all the best, all the our executive board member also.
Thank you. Thank you so much, sir. Your presence itself is a great motivation to all of us. Thank you so much for being here. I now request our Chief Advisor. We are celebrating his birthday today by this program, Dr. Jagdish Chinnappa sir. Wishing you a happy birthday and request for your remarks and concept note.
Thank you very much, Priya, for inviting me to speak. They say that you should spend your birthday with family, and this is the best family that you can have. So thank you all very, very much for wishing me. I'm so happy that today is the 13th day and that my birthday fell on this particular day. So we are going to have a wonderful program from the Northeast, and I'm eagerly looking forward to hearing from this one of the oldest medical colleges in the Northeast. And I'm sure that each one of these colleges has contributed to the growth of the Indian Academy of Pediatrics in a phenomenal way. So I thank the Central IIP led by Dr. Basavaraj and Dr. Yogesh Parekh and others for giving me this opportunity to look at how we can integrate all these institutions and their learnings together. Towards the end of this program, we are going to have this unique program by Dr. Pramod Jog, which I call Jogisms. And I'm sure that we will try to collect all these Jogisms somewhere and present it to everybody. So thank you very much, and let's have a wonderful afternoon.
Thank you. Thank you so much, sir. Wishing you a very great day and a year ahead. And thank you for this magic idea for giving this Academics with Institutions program to all of us. Thank you, sir. Now, I hope Chief Guest sir has joined. Santanu sir?
Yeah, he is not able to join, it seems.
He has joined through
Dr.
the viewers
Santanu?
link. Again, I have sent him the panelist link, so I am not
Sir, if
sure whether he has
anybody
joined. I can't see him, sir.
help sir out.
No, he said like he's not able to join. So that's what he said. Can we send him?
Link
again
has
the
been
link?
sent again. I have sent him on my mail, on his
Okay.
mail just now.
Okay.
Okay.
He doesn't serve already on delivery.
Someone may help him. Someone may help him. Ask someone to.
After sir comes, we can have his introduction and his remarks.
Yes, ma'am. Yes, ma'am.
Yeah, I would now request the East Zone Coordinator, Dr. Kalpana Datta ma'am, to introduce the chairperson, Dr. Aarti Tikka ma'am, and continue with the presentation of overview of institution so that after the chief guest sir comes, we can have his remarks. Over to you, Kalpana ma'am.
Yes, thank you, Dr. Priya. And good afternoon, everyone. Respected President Dr. Basavaraja, Honorary Secretary General Dr. Parekh sir, and Dr. Atanu. Yes, Dr. Atanu is there. National Treasurer Dr. Atanu. All the VPs, and especially this time the Shantanu, Dr. Shantanu is his own VP of the Eastern program. All the other OBs and all executive board members of 2024, and our chief guest, Dr. J. Sharma sir. And I also welcome the ma'am, Dr. Aarti Dekha ma'am. I personally know her very well. When I went to take MD exam in Guwahati Medical College, she was the HOD over there. And now she is retired. And just a minute, there's a some problem. Just exit. Yeah. She passed her MBBS long back, 1976, and then MD in HE1. And thereafter, she joined the government medical college, that is Assam Medical College. A professor, and she was a professor for 14 years, and also the HOD. And she is the vice principal of MCH Badbeta. She was an MCI assessor for last 15 years. She is an examiner for both UG and PG, and published many papers in national and international journal. Presented many papers in the different conferences and journals. She trained in neonatology at AIMS, New Delhi, and worked as a faculty and child survivorship motherhood, right? RCH1 to IMNCI, FIMNCI, FBNC, KMC, lots of government programs as a facilitator. And she retired from the service after 36 years of service in 2020. Now she is free to do her own job and she is now consulting in some private hospital. So with this, she is having lots of other things without wasting time. I am requesting Dr. Aarti Dekha ma'am, please come and take a chair and now the stage is yours. Ma'am, Dr. Aarti ma'am.
Thank you. Am I audible?
Yes, ma'am.
Yes. Good afternoon, everybody. It is my actually privilege to be here in this platform where one of the most loved and old medical college in Assam is now today. The students, they will be presenting the cases and in this platform. So I am grateful to all of you and thank you all. Now, my first job is to introduce the head of the department, Dr. Rita Bora. So she was my student while I was in Dibrugarh. Though I have not studied in Assam Medical College, Dibrugarh. I had studied in Guwahati Medical College, both in my undergraduates and postgraduates. But I have joined my journey in pediatrics in Assam Medical College way back in 1984. So I have a very soft corner for Assam Medical College. I was there for 10 years. 10 years. So at that time, Rita Bora was our student, both undergraduate and postgraduate. Now she is both postgraduate and undergraduate, a teaching experience for 30 years, presently working as professor and head of the department of pediatrics and neonatology in Assam Medical College, Dibrugarh. And she is a national faculty for FBNC training, member for accreditation committee of NNF, and contributors to Government of India manuals for FBNC, KMC, COVID-19 positive neonates, past secretary of NNF Assam, president Assam state chapter of NNF, and a DM examiner also for West Bengal, AIMS Rishikesh, and MD examiner for Guwahati, Dibrugarh, Silchar University, and also of Delhi University. So past executive body member of IIP, neonatology chapter, and NNF India, 46 publications, both international and national journals, and 9 book chapters. Won IIP Neonatology Fellowship in 1995 and won the Gyani India Fund, American Academy of Pediatrics, visiting fellowship in 2011. Presented paper in international conferences like FIGO in Cape Town in 2007, past Denver in 2011, in Vancouver 2014, Geneva in 2018, and Asia Oceania Perinatology Conference Delhi in 2010. So she has a long biodata in to her credit. So I now request Dr. Rita Bora to speak about Assam Medical College. Dr. Rita.
Thank you, ma'am. Thank you, ma'am. I'll now start sharing my presentation. So my slides are hopefully visible.
Yes, ma'am. Yes, ma'am.
Yes.
Okay.
Yes, ma'am. Yes, ma'am.
So good afternoon, everyone again. It is indeed a great privilege for all of us from Assam Medical College to get this opportunity to participate in this excellent academic activity initiated by Central IIP. And I, on behalf of the department, thank the respected office bearers of IIP for initiating this program as well as giving us this opportunity to participate today. So very shortly, I'll be introducing Assam Medical College as well as the Department of Pediatrics. So Dibrugarh, where Assam Medical College is situated, has a unique history of its own. Created by East India Company on the bank of one of Brahmaputra's tributary Dibrugarh. Dibrugarh was established in 1840. So you can understand that Dibrugarh name comes from the river Dibrugarh. And it was established here because of the abundance of natural resources around this place. We have oil and natural gas, coal around us, as well as this area is very suitable for tea plantation. The first medical institution of Northeast India was established in Dibrugarh as Berrywhite Medical School in 1900 with patronage of Sir John Berrywhite, the then civil surgeon. The school was later converted to Assam Medical College in 1947 on 3rd of November with Captain Hem Borua as the first principal. So here we can see the inception of our alma mater. It was opened on 3rd November 1947 by late Gopinath Bordoloi, who was called the Prime Minister of Assam at that time. The first batch was admitted in September 47 and graduated in 1952 under Guwahati University. AMC was recognized by General Medical Council of England in 1954. So we have passed 75 glorious years of service to the nation as well as to the northeast part of the country, and we celebrated our Platinum Jubilee in 2022. To commemorate this occasion, the Postal Department also released one stamp in honor of the service which this college has provided to the nation as well as to this northeast region. The first course of post-graduation started for ophthalmology in this college in 1959-60, and at present we have 200 MBBS students admitted per year with 20 postgraduate courses and 3 super specialty courses, namely for cardiology, plastic surgery, and pediatric surgery. Apart from this, we also have degree courses for nursing, dentistry, pharmacy, and emergency and trauma medicine. We have 1,940 indoor beds, and we cater to 1,500 to 2,000 OPD patients per day who come not only from Assam but also from the neighboring states of Assam, like Nagaland and Arunachal Pradesh. Our department was established in 1969 with contribution from UNICEF, and the first SOD was Professor Sankhadar Borua. DCS was started in 1969 with MD course started from 1970. At present, we have 10 MD seats per year with 3 DCS seats. And this is the faculty list. The newborn unit under pediatrics was inaugurated on 18th of February 2008 and with 12 beds. And now we have 85 beds with 35 inborn, 25 outborn, and 25 KMC beds. The postgraduate students are posted at least for 9 months in this newborn unit. And you can see that this newborn unit is a family-friendly newborn unit. Mothers are given health talks regarding benefits of KMC, breastfeeding, etc. on a routine basis by our nursing staffs. And they take, the mothers, they take part in the care of their newborn inside the NICU itself, starting with KMC, feeding, etc. under the supervision of our nurses. We also have an outborn unit, and we have facility for keeping the mothers of the newborns who come from outside in house so that they can also take part in the care of their own newborn. Our newborn is also the regional collaborative center for facility-based newborn care training for Northeast India. There are 5 such units all over the country. One of them is ours. We have trained till now more than 1,000 health workers from 8 states of Northeast region with through workshops as well as observers training. We had also organized a 4th E-Zone and Neocon on 2023. Apart from the facility-based newborn care workshops, we also conduct regularly workshops on different topics important for neonatology, inviting national faculties. So you can see some of the pictures here of FBNC workshop and observership training, which lasts for almost 14 days for doctors and nurses who come from Northeast states. And these are some of the pictures of workshops that we had conducted in the last 2 years, like the CPAP workshop, NEOMAP workshop, which deals with neonatal procedures, quality improvement initiative workshop, non-invasive ventilation workshop, as well as mechanical ventilation workshop, human milk banking workshop, and developmental supportive care workshop, inviting faculties who are from different parts of the country who are experts in these topics. We also do mentorship of different SCNUs. So 2 pictures are here of mentorship, which we had conducted last year, one in Silchar Medical College and one in Connestas Hospital, Shillong. The addition of human milk bank has been an excellent addition in the last year. So our milk bank is named Snehavandhan. And with this addition, we have been able to exclusively feed our neonates in the NIC with mother's own milk, as well as donor milk. We have a follow-up clinic where we follow up our NICU graduates. Many precious ones have been salvaged, and they come on a regular basis to our neonatal follow-up clinic where our students can learn about neurological examination of newborn as well as developmental screening test. Apart from the DIEC, we also have an early intervention center in cooperation with one of the NGOs, and early intervention is also done there. We also have a well baby clinic where vaccinations are being given, as well as training of nursing staffs are being done regarding vaccination. And then in the nephrology unit, we do peritoneal dialysis on a regular basis. One of the faculties who is interested in nephrology does also hemodialysis in collaboration with the adult nephrology unit. And the thalassaemic and sickle cell anemic patients, they come for daycare center to our unit. And the oncological case managements are also done by one of the faculties who is interested in oncological case management in a chemotherapy unit, special chemotherapy unit, which we have in the department. In the pediatric intensive care unit, we have 10 beds, 6 beds in the recovery area and 15 beds in the SDU. This facility, which has tertiary level care, is available not only by patients from Assam, but also from the northeastern region, other states like Arunachal and Nagaland. In the pediatric ward, we have 80 beds, and it's I'm happy to inform that the postgraduate students, apart from their daily clinical work, they interact in the evening routinely with attendants, sharing knowledge regarding health, hygiene, immunization, screen time, etc. And for that, they take the guidelines for parents published by IAP as a basis for their knowledge. So utilizing this, they give routine health talks to their attendants, and also they make posters in local language to facilitate their teaching. Our faculties are also organizing different workshops like FIMNCI, SBA, BLS, NELS, etc., where students also take part. Our students are also involved in different health camps, which the department organizes along with other organizations. And along with the nurses who are posted in our department, the students go for street drama, etc., so that they can spread the knowledge regarding different health issues like breastfeeding, ORS days, etc., amongst the general population. So in the Department of Pediatrics, Assam Medical College, we are trying our best to teach students recognize the health needs of pediatric patients and carry out their professional obligations ethically. We are trying to help students acquire the competencies related to pediatrics so that they can use these competencies in health facilities as well as in the community. We are trying to help them acquire effective skill in communication with children, their family, as well as the community. We are teaching them research methodology, and we are trying to help them teach paramedics as well, and trying very hard to instill in them a habit to learn what is new in their field every day. So as William Osler said, the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. We are trying to instill this feeling into them. Thank you for your patient hearing, and happy Rangali Bihu to all of you. And also happy birthday to Dr. Jagdish. Thank you, sir. Thank you.
Thank you, Rita.
Aarti ma'am, I would like to interrupt for a few minutes.
Yes.
Thank you so much, Dr. Rita ma'am, for that wonderful presentation. With the black and white photos of the college and the first batch photo, it was really heartening to see the pictures. I would now request our East Zone Vice President, Dr. Santanadev sir, to introduce our chief guest. We are honored to have your presence here, sir. Warm welcome to Dr. Gnanendra Sharma, sir. Over to you, Dr. Santanadev.
Are you there, sir?
Okay. Link. He has received a link. Probably he will join. That is what he said. We are connected to him.
He said that I'm in, so I asked him to switch on his video. So I'm not.
Sir, please switch on your video, sir, if you are in the panel.
Video on.
I think sir has not yet joined, sir.
Maybe. We can go ahead with the next
Aarti ma'am,
program.
please go ahead, ma'am.
Okay. Thank you, Dr. Rita, for your exhaustive introduction of Assam Medical College. It was very nice.
Video.
Yes, she has joined.
Rita ma'am, please mute yourself.
Yeah. So our next, your next program is keynote address by Dr. Arpita Gogoi, who is an associate professor of pediatrics in Assam Medical College, Dibrugarh. She has a special interest in pediatric nephrology and she has a ISPN fellowship from All India Institute of Medical Sciences. Also a national faculty for FBNC and IIP, ALS and BLS and for advanced NRP, and both UG and PG examiner. Now, without wasting time, I request Dr. Arpita to give your keynote address, and I request you to please keep your time.
Good afternoon, respected seniors, colleagues, and dear students. It is a great honor for me to present the keynote address today in this august gathering of eminent academicians and clinicians from across the country, and I am privileged to represent the Department of Pediatrics, Assam Medical College, Dibrugarh. Today, I shall be speaking on a relatively rare, though potentially life-threatening, condition that may complicate common, seemingly innocuous acute renal illnesses in children. My talk is on rapidly progressive glomerulonephritis, and it is a case-based discussion. Slide change to one. Am I audible?
Yes, yes.
Yeah.
Go on.
Yeah, there was some glitch with the slide. So rapidly progressive glomerulonephritis, or RPGN, it describes the clinical course of several forms of glomerulonephritis with a common histopathology showing crescents in the glomeruli. It starts as an acute nephritis with hematuria, renal insufficiency, and hypertension, and subsequently there's a rapid loss of renal function. Though post-infectious or post-streptococcal GN is common in children, a few cases may go on to develop an RPGN course. It is a medical emergency and needs prompt recognition and therapy for optimal renal outcome. If left untreated, death from renal failure may occur in weeks to months. Definition-wise, it is a clinical syndrome which is characterized by rapidly, that is over a period of days to weeks, worsening GFR and increasing serum creatinine, with an urine analysis suggesting acute GN in the form of microscopic with or without gross hematuria, RBC casts, and proteinuria, and a renal biopsy showing glomerular crescents. There are many causes of crescentic or rapidly progressive glomerulonephritis. We mentioned the rare causes here, but the focus of today's discussion is on causes of RPGN which are prevalent in children. Our first case is an 11-year-old boy who came with colored urine, decreasing urine output, and periorbital edema for a week with breathlessness for 1 day. There was a past history of multiple pyodermas in lower limbs 3 weeks back. There was no history of sore throat. The high-colored or red-colored urine was painless. It was present throughout the micturition stream, and there was no history of drug, dye, or bead ingestion. There was no history of accompanying fever, colicky abdominal pain, diarrhea, bleeding, or trauma. There was decreasing urine output for around 5 days before admission with dyspnea and orthopnea for 1 day, along with facial and generalized body swelling. There were no systemic symptoms in the form of rash, joint pains, ulcers in the oral cavity, cough, seizures, or focal deficits. On examination, the anthropometry showed a normally grown child with vitals revealing a BP in the stage 2 hypertension range, and general examination revealed periorbital puffiness and healed pyoderma scars over the lower limb. There were no bony deformities. On systemic examination, there were features of fluid overload with basal crepitations in both the lung fields and minimal ascites with tender hepatomegaly. The other systems were normal. On investigation, the urine routine showed a positive urinary sediment with plenty of RBCs and casts with a urine PCR which was in the subnephrotic range. Hemogram was normal, and urea and creatinine at onset was markedly deranged, which gradually declined to near normal levels after some days of therapy. The USG KUB showed normal-sized kidneys with bilateral raised renal cortical echoes and mild ascites. So this was an 11-year-old boy with acute nephritis with hypertension and features of fluid overload. So this was essentially a rapidly progressive renal failure with a short history without any growth failure, significant anemia or mineral bone disease, and normal-sized kidneys on ultrasound. So these features helped us to rule out CKD as the cause of the child's ailment. So this term rapidly progressive renal failure or RPRF is progressive renal impairment over a period of weeks, and it consists of a group of clinical syndromes out of which RPGN is one of the causes. So RPRF can have systemic or renal causes. In systemic, we have vasculitis like Wegener's or Church-Strauss, or we can have SLE like class 3 or 4 SLE nephritis with or without APLA, or we can have thrombotic microangiopathy, which is seen in HUS or TTP. In the renal category, we can have glomerular diseases. These are classically known as RPGN, or we can have tubulointerstitial diseases like acute interstitial nephritis, and we can have vascular causes like renal vein thrombosis. In view of the absence of systemic symptoms, we could rule out systemic causes like vasculitis and SLE. On the other hand, the ultrasound was normal, so renal vein thrombosis was also less likely. That left us with the possibility of RPGN strongly in our case, also in view of the positive history and urine analysis reports. Further investigations were done, which showed C3, which was very low and a very markedly raised ASO. ANA and ANCA were negative, so were the viral markers. Now, when complement is low in such a case, then the possibilities that remain with us are either post-streptococcal or post-infectious GN, lupus nephritis, membranoproliferative GN, or C3 glomerulopathy. In such a case, if complement is normal, then we could suspect IgA nephropathy, Hinox-Conlin purpura, or hemolytic uremic syndrome. So our patient fitted into the first category, and given the fact that he had a rapidly progressive course, he was a strong candidate for renal biopsy, which was performed, and the light microscopy showed diffuse proliferative glomerulonephritis with crescents in more than 50% of the glomeruli. But the fortunate thing was that most of the glomeruli were cellular with no fibrous changes, so he was amenable to treatment. On immunofluorescence, there were lumpy, bumpy, characteristic coarse granular staining in the capillary loops and mesangium, which is characteristic of, and these stained positive for IgG and C3 very strongly. On the other hand, electron microscopy showed an irregular glomerular basement membrane with breakages at some sites, along with subepithelial hump-like deposits and effaced podocytes. So all these findings confirmed our suspicion of PSGN complicating RPGN, and the treatment started was antihypertensives were given along with treatment of fluid overload by 4 sessions of hemodialysis, which were given over the next 10 days. There is an evidence for use of immunosuppression if there are crescents on crescentic glomerulonephritis on biopsy of RPGN cases, even if they are post-streptococcal. Hence, daily IV methylprednisolone pulses were given for 3 days, followed by monthly pulses of cyclophosphamide for 6 months, along with tapering doses of steroid and mycophenolate mofetil for 12 months. On follow-up at the end of 4 months, the creatinine and urine protein creat ratio normalized, as did the C3, and the child was off antihypertensive medications, and the child is doing well on follow-up. The second case is a 9-year-old girl who presented with complaints of fever, headache, malaise, and reddish skin lesions on both lower limbs for 2 weeks, with bilateral knee pain and swelling for 10 days. There was crampy abdominal pain, oliguria, hematuria, and anasarca for 7 days. There were no bleeding manifestations, oral ulcers, cough, or hemoptysis. On general examination, there was bilateral pedal edema with a typical skin rash, which was seen more on the extensor aspects of the legs, which was reddish, purpuric, and non-tender, classically described as palpable purpura, and with some arthritis in both the knees. There was minimal periumbilical tenderness, but there was no free fluid. Vitals revealed a blood pressure which was in the stage 1 hypertensive range. So this was essentially a systemic vasculitis in view of the rash and arthritis. Our first possibility was IgA vasculitis or HSP. However, we also needed to rule out lupus, ANCA-associated vasculitis, and IgA nephropathy as other systemic causes. On investigations, platelet count was normal, so was the coagulation profile. The urea creat was deranged, and the ASO, ANA, ANCA all were negative, and the C3 and C4 were normal. The urine RBCs and albumin was strongly positive, with stool occult blood also being positive. So this was an IgA vasculitis with RPGN. In view of the RPGN state, a biopsy was performed which showed 50% of the glomeruli having crescents, and out of those, 50% had circumferential crescents, but again, all were cellular without any fibrocellular elements. On immunofluorescence, there was strong positive staining for IgA antigen, and electron microscopy showed immune deposits in the mesangium. All these are characteristic findings in HSP nephritis. Management-wise, the child was managed supportively with fluid electrolyte balance being maintained. Peritoneal dialysis was initiated and continued for 72 hours. He was given antihypertensive medications and a planned diet was prescribed. In view of the extensive more than 50% glomerular crescents, the child was pulsed with methylprednisolone for 3 days, followed by oral prednisolone in tapering doses over the next 12 months, with oral cyclophosphamide given for the initial 3 months, followed by mycophenolate mofetil for 12 months as maintenance. The serum creatinine dropped to almost normal at discharge, and the child is on regular follow-up with us. Coming to the pathogenesis of crescents, the primary insult is endothelial injury. Here we can see the endothelium, the glomerular basement membrane, and the epithelium. So there is endothelial injury, which leads to breakage and rupture of the GBM. This leads to fibrin deposition in the Bowman space or the urinary space, which triggers the coagulation cascade. Fibrin stimulates the parietal epithelial cells to proliferate, leading to the formation of cellular crescents. These crescents in turn exert pressure on the glomerular tuft, causing tubular obstruction and tubular ischemia, and ultimately leading to decreased renal function. Crescents are essentially composed of fibrin and parietal epithelial cells. During the acute phase, crescents are predominantly cellular, whereas chronicity is characterized by fibrosis and sclerosis. So we need to act when the crescents are cellular, because once chronicity sets in, reversal becomes difficult. Crescent formation is a delayed type of hypersensitivity reaction. Here we can see the same changes described diagrammatically. This is an intact GBM in green. However, in the second picture, we can see that there are breakages in the GBM, which leads to escape of fibrin, plasma proteins, and inflammatory cells into the urinary space, leading to proliferation of the parietal epithelium of the glomerular basement membrane of the urinary space. This and subsequently, after a few days, there is infiltration by interstitial fibroblasts and macrophages, leading to fibrocellular crescents and scarring, which becomes irreversible. Coming to the types of crescentic GM, there are basically 4 types, which are identified best on the basis of immunofluorescence microscopy of the kidney biopsy. Type 1 is anti-GBM disease, in which there are antibodies against the alpha-3 chain of type 4 collagen. This particular antigen is present in the pulmonary capillary membrane as well as the glomerular basement membrane. And this syndrome is typically known as Goodpasture syndrome. It presents with hemoptysis as well as glomerulonephritis, and this is seen usually in young adults, much less common in children. In children, the commonest variety is immune complex GN. This is designated as type 2, and the secondary causes of ICGN may be post-infectious, lupus nephritis, IgA vasculitis or HSP, and membranoproliferative GN. There is another type, which is type 3, which is pauci-immune. This is characterized by lack of immunofluorescence on the kidney biopsy, on immunofluorescence. However, there is ANCA positivity in the blood, and these patients are usually cases of ANCA-associated small vessel vasculitis. This can be either renal limited or systemic in the form of GPA, MPA, or EGPA. There's another type, which is type 4, where anti-GBM as well as ANCA antibodies are positive. On immunofluorescence, linear staining is characteristic of Goodpasture syndrome, whereas granular stippling is characteristic of type 2 or immune complex glomerulonephritis, whereas in type 3, there is hardly any immunofluorescence. So these are 3 glomeruli at different stages of evolution. In stage 1, we can see much of fibrin, and there's a segmental glomerulus here and circumferential here. And this is a reversible stage, whereas if it goes into fibrocellularity or fibrous transformation, which occurs in weeks, then it becomes irreversible. Electron microscopy findings. There are breakages in the glomerular basement membrane seen in all types of GN, which is the basic pathogenic mechanism. Characteristic deposits of immune complex may be seen in type 2 GN, but in type 1 and type 3, no characteristic deposits are seen. These are the small vessel vasculitides or ANCA-associated vasculitides, which can present with a RPGN course. The diseases involved here are microscopic polyangiitis, granulomatosis with polyangiitis, earlier known as vaginous granulomatosis, and eosinophilic granulomatosis with polyangiitis, earlier known as Churg-Strauss syndrome. So this can be either systemic in the form of these 3 lesions, or it can be a renal limited vasculitis. So predominance-wise, immune complex GN is the commonest in children, with 45% of all children having ICGN. Diagnostic evaluation includes the basic biochemistries, CBC, PBS, biochemistry to look for renal derangement and dyselectrolytemia, urine analysis to look for RBCs, cast, and protein. We need to look for complements. Strep infection needs to be ruled out, and lupus, P ANCA and C ANCA for ANCA-associated vasculitis, ESR and CRP for severity and remission. Renal biopsy is mandatory in all cases of RPGN with light and immunofluorescence microscopy, and if possible, electron microscopy. Some specific tests may be indicated in certain illnesses. A word about anti-neutrophil cytoplasmic antibodies. These are positive in the type 3 crescentic GN. We can see here cytoplasmic staining of the neutrophil. This is C ANCA, and this is seen mainly in vaginous granulomatosis, and the dye involved is protein. The enzyme involved is proteinase 3. Whereas in the other picture, we can see neutrophils where there is a perinuclear enhancement, and that is why it is known as P ANCA. And this is myeloperoxidase staining, and this is seen mostly in microscopic polyangiitis and drug-related vasculitis. What about the management? Initial therapy is similar in all cases of RPGN, irrespective of the cause. There are two phases. First, we need to induce remission to control the inflammation, and this is done by intensive immunosuppression using steroids and cytotoxic agents. Followed by a maintenance phase to prevent relapses and further renal damage, which should be continued for at least 2 to 4 years. At the same time, in the acute stage, fluid electrolyte management, including renal replacement, is instituted, and plasma exchanges may be necessary in some cases. Response is uniformly poor in type 1 and type 3 disease. However, in type 2, response depends on the cause, and amongst all type 2, post-streptococcal glomerulonephritis has the best prognosis. Outcomes: in post-streptococcal GN, dialysis-dependent AKI or RPGN occurs in around 3 to 5% of cases. However, the prognosis is excellent in these cases with proper treatment, and end-stage kidney disease in these cases is rare if managed properly. On the other hand, with HSP nephritis, all children with HSP nephritis and a subsequent RPGN need to be followed up diligently, because 20% of such cases may progress to end-stage kidney disease, and this accounts for 2% of all renal transplants. Hence, we need to follow up these patients for renal functions, urine routine, and BP monitoring. In conclusion, though rare per se in children, rapidly progressive glomerulonephritis may complicate common pediatric conditions like post-infectious GN, post-streptococcal GN, and IgA vasculitis. We need to distinguish RPGN from other causes of rapidly progressive renal failure like hemolytic uremic syndrome. Intensive immunosuppression is necessary in the initial stages to halt the disease process, with specific management tailored to the underlying cause if present. And while RPGN due to post-infectious GN or HSP nephritis has a better outcome, ANCA-associated vasculitis or membranoproliferative GN have poorer renal outcomes. Thank you.
Thank you, Dr. Arpita, for your excellent presentation on the keynote address that is on RPGN. Now, anybody has any queries? Any queries?
Very well presented. May I ask one thing? Very nicely presented this way. But this is always a pathological diagnosis, right? RPGN. What prompted you to consider biopsy in that child? And when was the methylprednisolone started? Because that is the main treatment part. So initially you were managing as acute nephritis. So what prompted you? Because it is a post-streptococcal, you will always feel the child will recover. So what prompted you? At what stage the biopsy was done? And when was the methylprednisolone started? That's my question. And secondly, one more thing is that post-infectious RPGN is less common as compared to the other causes. This is what we have seen.
Right. Yes, sir. Sir, RPGN is much less common following post-infectious or post-streptococcal glomerulonephritis. However, it is seen in a very few number of cases. In our case, the patient already was at home for 7 days with the illness, and when he presented to us, his serum creat was 5.7, and plus he was oligoanuric. So, in view of that, as well as positive, strongly positive RBCs and proteins in the urine, we thought that, and plus he was also anuric and he needed dialysis right at the beginning. So we suspected that this child had gone on to become an RPGN, and that is why we did the biopsy, and which revealed more than 50% of crescents, which was an indication for starting immunosuppression in this child, sir. So basically the oligoanuria plus the very high creatinine levels on admission.
That was not.
So my message was that even though it is rare in children, if such a post-streptococcal child presents with this kind of presentation, we need to keep RPGN in mind. So
methylprednisolone was started after the biopsy report?
No, we did not wait for the biopsy report. We collected the sample and then we started methylprednisolone immediately. So we can start methylprednisolone. Meanwhile, the biopsy report comes. The immunofluorescence and the light microscopy comes pretty soon, within 1 week. And for the electron microscopy, we need to wait, but that will not change our management. So we can start right away in such a clinical scenario.
Okay, thank you.
Excellent presentation, Dr. Arpita. Just one or two clarifications. Is there any pattern of urine protein excretion which differs from in these children compared to the others? Previously, we used to do, urine protein electrophoresis used to be done to look at the pattern of urine protein secretion in these children. So is there any data on that?
So not as such, not that we are not doing protein electrophoresis nowadays, sir. And based on the clinical picture of a rapidly progressive course, a biopsy was considered, and there was anyhow subnephrotic range proteinuria was there in this child as well, but we could not document the 24-hour urinary protein levels.
The other thing is that you had mentioned that you are doing the complement levels in all these children to find out hypocomplementemia. Are there any other immunological tests you're doing? Because right now there is move towards doing more extensive immune workup to find out the pattern of immunological damage in the glomerular basement membrane.
Yeah, in these cases, we could not go ahead with the other tests, sir. We did the ANCA serology, the ANA, and the complement, and plus combined with the renal biopsy in view of the RPGN course, that sufficed. That was what was available to us, and then we went ahead with the treatment for these children.
But anyway, I must congratulate you for an excellent presentation. Really excellent. Fantastic. Congratulations.
Thank you, sir. Okay.
Thank you. Thank you so much, Dr. Gogai, for that wonderful presentation. I now request our Vice President, Dr. Santanu Deb, sir, to introduce our Chief Guest, Dr. Jain Sharma, sir, is here. Hearty welcome to you, sir. We are privileged to have you in this platform today. I request Santanu, sir, to introduce our Chief Guest.
Thank you, Dr. Priya. It is my proud privilege to introduce sir, who was my teacher also, Dr. Jain Sharma sir, Dr. Gyanendra Nath Sharma sir. He is the retired professor of pediatrics at Guwahati Medical College, Guwahati, Assam, and of neighbouring Shillong, Meghalaya. Sir needs no introduction actually to the pediatricians and also the lay citizens of Assam. He is so popular and so famous. And also to the pediatricians of Northeast and Eastern India and to many other parts and many other pediatricians in other parts of India, because he is a towering personality in the field of pediatrics and education, pediatric education. He passed his MD from Assam Medical College, Dibrugarh, the institute that we are focusing today, in 1978. And then after which he had an illustrious tenure in the medical colleges of Assam, mainly in the Guwahati Medical College for about 35 years as a faculty in various positions, and he finally took voluntary retirement from Guwahati Medical College as professor and HOD. So during his tenure at Guwahati Medical College, especially after he took over as HOD from 1998 or 1999, many infrastructure changes have taken place in the department and creation of new neonatal unit and other facilities. And he has also been one of the pioneers of neonatal care in Northeast India. During his tenure as a teacher, he has impacted thousands of undergraduate students and a large number of postgraduate students. He is renowned for mentoring and guiding his students, both academically and in life also. And I am one of the beneficiaries of his mentoring, and most of the pediatrics that I know, I have learned and imbibed from him. He continues to be a friend, philosopher, and guide to many of his ex-students. He is extremely knowledgeable and a thorough academician, and I'm sure he perhaps reads much more medical literature than most of us even today. His areas of special interest when I was a student were neonatology, nephrology, hemato-oncology, community pediatrics, and so many more. He excelled in everything. He has astute clinical skills. He is a teacher par excellence, and sir loves to teach, and his classes are really memorable, both for undergraduate and postgraduate students. His textbooks are also extremely popular among students, and he has written quite a few textbooks, and they continue to be very useful for the undergraduate and the postgraduate students. He continues to be involved in teaching and is currently responsible for teaching postgraduate students at Apollo Hospital, Guwahati. He is a disciplinarian and always very, very punctual. Today was an aberration because of technical issues, but otherwise he is actually very punctual. He has been responsible for organizing numerous CMEs conferences, including the National Conference of NNF at Guwahati several decades back. He has been an examiner at various universities. He is an accomplished speaker and has delivered several orations. He is the recipient of many awards and recognitions, both from academic bodies and civil society also. He took voluntary retirement from Guwahati Medical College in 2014 and then proceeded to the Department of Pediatrics at neighbouring Shillong, Meghalaya, and he worked there till 2016. Post-retirement from government service, Sir has been actively involved in community activities and literary pursuits, and is an avid writer and speaker on social issues, and he also has the zeal of a social reformer. He regularly translates world poetry and prose to Assamese, and he is an avid photographer and traveler. Sir, we would be very privileged if you can say a few words, but you have to unmute and then say the words, sir. Thank you so much. Yes, sir.
Good afternoon, everybody. So, first of all, let me say sorry, because this is probably the first time in life I could not attend a meeting in time. And so, anyway, I am very thankful to the organizers for two reasons. One is for having such academics throughout the country, very good. And secondly, for inviting me as a chief guest to such a gathering. So, my connection with Assam Medical College is for 2 years during my postgraduates. And I always used to say those 2 years of post-graduation and staying in the AMC, Assam Medical College campus, was just memorable. And I still remember because the other medical colleges in Assam, where from I did my undergraduate, Berrywhite Medical College, do not have a campus, but the Assam Medical College started with a campus, a beautiful campus, a good library from which I got a lot of help. So I always remember Assam Medical College. So I was happy when Rita asked me to be present in this academy. So thank you very much. Thank you, everybody, the organizers of IAP, as well as the organizers in the state, especially Dibrugarh, Rita, Santanu, for inviting me. And thank you very much. I wish all the best. I've seen a very long list of academics, and I hope that it comes out to be 100% successful. Thank you very much.
Thank you, sir.
Thank you. Thank you so much, sir. It means a lot to have your presence in this platform today. Thank you so much, sir. I would now request Dr. Aarti ma'am to continue with the next presentation.
Okay. Now the next topic is on research by Dr. Okupa Islam. And she is an associate professor of Assam Medical College. She has a teaching experience of nearly 15 years and is working in neonatology unit also for last 10 years, trained in allergy and asthma, and also instructor in advanced NRP and BLS, research person in Government of India programs like FBNC, SBA, and BMO. She is a past president of IIP Dibrugarh City Branch. Now I request Dr. Okupa Islam to deliver her address.
Thank you, Madam. Good evening, everyone. I shall be presenting the research publications of our department, some of the research publications, though we have many. Due to time constraints, I'll be presenting few of the research publications. So starting with the publications from the neonatology unit, the study on the prevalence of anemia in pregnant women and its effect on the neonatal outcomes in Northeast was done, where it was found that anemia is quite prevalent in the rural pregnant women, and it is associated with increased risk of small for gestational age and preterm babies. These are two interventional studies which showed that improved in iron status at 6 months of age. The first one was the effect of iron supplementation from neonatal period on the iron status of 6-month-old infant at risk for early iron deficiency. It was a randomized interventional trial, and this also backed the best paper in the annual conference of IIP Neocon. And second study of the effect of 40 centimeter segment umbilical cord milking on hemoglobin and serum ferritin at 6 months of age in full-term infants of anemic and non-anemic mothers. Like anemia is quite common in the developing countries, and most of the infants, by 50%, develop anemia by 1 year of age. And it was mostly iron deficiency anemia, which is associated with small for gestation, preterm deliveries, and iron deficient mothers. And also birth asphyxia is also common in the developing countries, but though DCC, delayed cord clamping, is a proven method, but it may not always be feasible in our settings. Now, in another study on complete enteral feed in stable low birth weight babies, which has been included in Cochrane and also is a part of the NNF guidelines. And based on this study, we are practicing the same in our unit. The next study on fetal intolerance and NEC on end diastolic pressure, it was for absent end diastolic pressure. It was found that SGA with absent end diastolic blood flow is associated with increased incidence of feed intolerance and NEC. And these two are two interventional studies. The first one was an exchange transfusion, double volume exchange transfusion, where a comparison between the peripheral vessel and umbilical vessel catheterization was done. And it was found that PVET is much safer and is associated with less complications and is also effective. But it is associated with technical challenges like it needs experience, expertise, and skill in placing the catheter. And the next study on the transitional hypoglycemic management in small for gestational age neonates, which occurs and express breast milk in resource poor settings. Based on this study, we have been now using oral glucose in transient hypoglycemia in our unit. And these two studies on G6PD deficiency in admitted jaundice patients showed an incidence of around 5 to 7%. And so screening of G6PD has been taken, and which has decreased the requirement of exchange transfusion, and also it has also helps in preventing intervention, taking measures for in later life. So this study helps in was a study on the use of pulse oximetry in the labor room to detect hypoglycemia was done, and this paper was also backed the second base paper in the neonatal IIP neonatal chapter annual conference. So following our outbreak in our unit of bullous lesion, a study was done and which showed which made us realize that bullous lesion during or soon after delivery may be associated with Bacillus cereus infection, and so it needs to be included in the differential diagnosis of bullous lesion soon after birth. So our hospital was a COVID hospital during the pandemic, COVID pandemic, and a few studies on COVID-19 were also taken up during the period on both on neonatology and older children. Now, coming to the presentations from the pediatric unit, interdepartmental corroborative study with funding from DBT was done on rheumatic heart disease, and based on the studies, these were the 3 papers were published in an international journal on rheumatic heart disease. This is a study on the clinical spectrum of VSD in children in a hospital. So several studies have been done on the clinic and the diagnostic and the prognostic markers of community-acquired pneumonia, and also the therapeutic effect of zinc was also studied in pneumonia. The study on the diarrheal disease in under 5, which is very common in our population. So a few number of studies were done on the clinical hematological profile and the biochemical markers, biochemical markers, and among the transfusion associated transfusion dependent hemolytic anemia. So these are the studies on thalassemia and sickle cell anemia. So this study on iron deficiency anemia in adolescents. So anemia has been found to be quite common in the adolescent and more so in the female population with a high risk of iron deficiency anemia. So these studies on the convulsive disorders were done in the and also a study on AES was done. So in the nephrology unit, several studies were done, of which significant studies on urinary indices in nephrotic syndrome and dyslipidemia in nephrotic syndrome was done, and a study on community-acquired urinary tract infection in children. So as you know, the SAM is a very common problem faced in a population of the developing countries. So but a recent study, this is the most recent study done in our department on SAM. The changes in the biochemical profile of children with severe acute malnutrition at admission and after nutritional rehabilitation. So this study is done in the pediatric intensive care unit, analyzing the outcome and the mortality pattern of the children admitted. So another study on pediatric burn in a tertiary care hospital of northeastern region, and another with a profile of acute poisoning and its outcome in children admitted to a tertiary care hospital in northeast India was also conducted. So now, so these are the present studies which I have presented. Now, many projects were also done in collaboration with ICMR, DBT, and INCLEN, and several projects and research work are still ongoing in the department. Recently, in a conclave held at the ICMR headquarters, New Delhi, Multidisciplinary Research Unit (AMCS) had been adjudged as the best performing MRU of the East and Northeast region. In the meeting, DG ICMR declared that MRU AMCH will be upgraded to MRU of Excellence, which will include some additional facilities of research, and hope we'll be able to come up with much updated research. Thank you.
Thank you, Akupa, for presenting the papers nicely. I think, is there any queries from the esteemed colleagues? Anything? So
We'll continue, ma'am.
yeah, okay. Then the next topic will be the case presentation by the students, PG students. And there will be 3 case presentation by 3 third-year MD students. And this will be moderated by Dr. Chandraduti Bora. I request Chandra to take over.
Ma'am, please ask them to mention the time.
Good evening, everyone. We will have 3 clinical cases that will be presented by our postgraduate students. The first case will be by Dr. Sarda Majumdar. She is a third-year postgraduate trainee. The second case will be by Dr. Ilora. Then the third case will be by Dr. Shruti Kaisap. I am handing over the mic to Dr. Sarda. Sarda, come.
Good afternoon, faculties. I'm Dr. Sharda Majumdar, PGT AMCH. A child is often unwary, impulsive, and inherently curious by nature, and can often land up in some uncommon but potentially debilitating injuries. One of such injury we have encountered in our pediatric emergency, and I'll be discussing the same. A 7-year-old developmentally normal male child was brought to us with history of touching a wire at school, followed by abnormal body movement and loss of consciousness. The child was brought within 3 hours of injury, and the circumstantial evidence suggested electrical injury. Upon arrival at the emergency room, primary assessment of the child was done, where he was hypoxic in room air, he had tachypnea with mild subcostal retraction, he had tachycardia with feeble pulse volume with hypotension, he was unresponsive with active seizure, and on exposure, he had blisters over the right palm. After admission into the emergency room, a detailed systemic examination was done, where on CNS examination, he was unconscious with a GCS of 8/15. He had hypertonia of all limbs, exaggerated deep tendon reflexes, extensive plantar response, and on other system examinations were within normal limit. So, we came to a provisional diagnosis of electrical injury with shock, which may be cardiogenic or neurogenic shock. After admission into the ER, the further management was according to the APLS protocol, where management of airway breathing and circulation was done. Antiepileptics were given for the control of seizures. Shock was managed as per protocol with 1 bolus of normal saline, followed by Ringer lactate for IV maintenance. Routine hematological investigations were sent. The child was catheterized for urine output monitoring, and ECG was done, which showed STT changes with T wave inversion, probably myocardial injury. ABG was performed, which showed partly compensated metabolic acidosis. Following the day, investigations came, which showed increase in total count with neutrophilia, with other hematological parameters, serum calcium and electrolytes within the normal range. Serum CPK was done, which came to be normal, with no myoglobinuria, and urinary came to be normal. Now, the subsequent clinical course in PICO is represented here graphically, and we can see almost all the vital organs being involved in the first week itself. A multidisciplinary approach has been taken for the management of the child with a team of pediatric cardiologists, neurologists, and nephrologists. Literature with electric injury were revisited to identify any other organ involvement. Here we can see in the cardiovascular involvement, the child presented with cardiogenic shock and was managed as per protocol and was passive by day 1 itself. And on day 4, the child had sinus bradycardia, which was passive by day 6. Subsequently, echocardiography was done, which came to be normal. On CNS involvement, the child presented with a poor GCS of 8/15 and in active seizures, and during the hospital stay, the child had to be managed with 4 antiepileptic drugs and simultaneously neurology consultation was taken. Later, EEG revealed diffuse encephalopathy and MRI brain came to be normal study. The seizures were controlled by day 10 and by day 15, GCS came to be 12/15. But the child had quadriparesis with hypertonia of all limbs, for which by day 17, physiotherapy was initiated and continued. There was also renal involvement in view of non-oliguric AKI, which was probably due to myoglobinuria, for which 1 session of hemodialysis was done. Hyperkalemia was managed with K-binders, infusion, regular insulin till normal potassium levels were reached. On ocular examination, the child had posterior dislocation of lens in both eyes, and the child also had fever with increase in total counts, for which empirical antibiotic was started, but upon arrival of blood and urine CS, the antibiotics were stopped by day 5. Here we can see on serial RFT monitoring, the child had normal RFT levels on day 1, but by day 3, there was progressive increase in urea and creatinine with hyperkalemia, for which 1 session of hemodialysis was done. And on day 4, there was drop in creatinine to 3.35, and by day 8, there was normalization of renal function parameters. ABG repeated came to be normal. Now, upon clinical improvement, the child was then shifted to ward where further management was carried on with oral anti-epileptic drugs. Tube feeding was continued and gradually spoon feeding was introduced. Physiotherapy was continued and parental counseling was done regarding the patient's neurological deficits, nutritional needs, need for follow-up, and physiotherapy. After a stormy course of 1 month, we were finally able to discharge the child with most challenges dealt with, but unfortunately, the child had some neurological impairment with disability in the form of quadriparesis with spasticity. The child had cognitive and audiovisual disturbances. The seizures were controlled on 3 anti-epileptic drugs, but the child was dependent on parents for daily activities with wheelchair assistance. At discharge, the child was advised to continue antiepileptics, nutritional care was taught to parents, and the importance of physiotherapy was re-emphasized. At 1 year follow-up, the child showed improvement on motor examination with significant improvement in power. The child is now ambulatory with assistance and is dependent on parents for daily living. The cognitive and visual disturbances are there, but the seizures are now controlled on 2 antiepileptic drugs. Now, coming to the discussion, although electric injury in children is uncommon, there is a risk and it can cause severe neurologic, cognitive, physical, and psychosocial impairment. Considering its severity, morbidity, and long-term sequelae, I would like to briefly discuss about this injury. Electric injury is almost always accidental and mostly occurs at home. The age group at risk is less than 6 years with low voltage injuries and more than 13 years with high voltage injuries. The risk ratio in childhood for male to female is 2:1. The household, our household has a voltage of 220 volts and the standard household current is alternating current at 50 to 60 hertz. The extent of damage done by electric injury is depending upon amount of electric current flow, type of current, current path, which tissues did it flow through, and duration. High voltage injuries are more dangerous. AC is more dangerous than DC as it causes tetanic muscle contraction with lock-on effect and can cause immediate cardiac arrest. Transthoracic has highest mortality. Wet skin increases the conduction and prolonged contact increases the severity. Electric injury directly can cause cardiac arrhythmia, peripheral nerve injury, etc. And conversion of electrical energy into thermal energy results in burns, and mechanical injury may lead to fractures and dislocations. Electric injury may almost involve all the organs, with the most common being cardiac, followed by renal. In cardiac, 15% present with arrhythmia, asystole, ventricular fibrillation, and conduction disturbances, as seen in our index case. The child may have AKI in renal involvement, as seen in our index case. In neurological involvement, there may be loss of consciousness, seizures, patchy motor sensory deficits. In skin, there may be kissing burns. Musculoskeletal involvement may present with fractures and periosteal burns, and there can be lens dislocation in eyes, as seen in our index case, with other system involvement. Now, the management for electric injury comes with pre-hospital management, where the first responders ensure de-energization of the lines, reverse triaging in case of mass casualty, and scene safety for lightning strikes. Further management is depending upon the APLS guidelines, where management of airway breathing and circulation should be undertaken. ECG is a must for all, as cardiovascular involvement is the most common. Skin and mouth should be examined for burns, particularly in young children, and all need admission, as late manifestations are common, as seen in our index case. Treatment involves prolonged CPR, reverse triaging, and aggressive fluid management. Monitoring should be done with 12-lead ECG, urine output, and 6-hourly electrolytes. Notification of the concern for the welfare of the child, where there is a concern for future harm. Now, is there any law in our country for safety from electrical hazards? Yes. Electricity Act 1956 and 2003 deals with the safety of electricity in India. BIS provides technical specifications for electrical appliance, and CEA formulated guidelines for safety in electrical power systems. 2021 guidelines on school safety and security given by Department of School Education and Literacy also emphasizes on electrical safety at school with periodic electrical audit. Now, what parents can do to prevent their children from such life-altering injuries? The parents can put child safety covers on the electrical outlets, keep electrical cords out of reach of children, follow directions when using electrical appliance, avoid using electrical appliance in the shower or bath, turn off the circuit breaker when working with electricity. In conclusion, I would like to say electric injuries are preventable. And we must remember, knowledge is power, but knowledge without action is meaningless. Creating awareness about electric safety and implementation of safety measures is of paramount importance where children are concerned. Thank you.
Chandra, your next case.
Yes, ma'am.
You can afford that. Questions are to be. Good afternoon, respected faculties. I am Dr. Ilora Borgoy. I'll be presenting a short case of trisomy 21 with a rare presentation. Down syndrome is the most common chromosomal abnormality and important genetic cause of intellectual disability. Features like growth failure, mental retardation, characteristic dysmorphic faces, congenital heart disease, etc. are known to us. We are presenting a newborn baby with a rather uncommon cardiovascular manifestation of Down syndrome. We received a single-term male baby of birth weight 3.3 kg delivered by elective cesarean section at a peripheral hospital and referred to us on day 2 of life with neonatal problem of respiratory distress. As per the maternal history, mother is a 29 years primigravida. She conceived spontaneously. It was initially a twin pregnancy with vanishing twin by 20 weeks of gestation, and she also had history of urinary tract infection in her 3rd trimester. As the baby has Down's phenotype, so karyotyping was done and it confirmed the diagnosis. The baby presented with respiratory distress of Down score 4 out of 10, requiring NIPPV mode of ventilation. Chest X-ray was suggestive of congenital pneumonia, and we started antibiotics as per our unit protocol. Also, a 2D echocardiography was done to rule out structural abnormality of the heart. However, very minimal pericardial effusion was noted on the day of admission. Initial laboratory parameters shows grossly elevated total leukocyte count of 65,300 per cubic millimeter. However, no immature cells were seen on the peripheral blood smear. So we arrived at a diagnosis of transient abnormal myelopoiesis, which is a pre-leukemic state exclusive to newborn with Down syndrome. Hypoalbuminemia was also noted, and we thought it to be the cause of minimal effusion seen on the echocardiography. Thyroid profile was also done on day 3 of life, which was normal. Our first challenge was to manage the TAM. Considering the baby was quite sick and on NIPPV mode of ventilation, we deferred the bone marrow biopsy. Serial monitoring of the total leukocyte count done, which shows a decreasing trend over time. Also, no immature cells were observed on the peripheral blood smear, so we considered conservative management for the TAM and planned a hematologist consultation once the baby is stable. On day 10 of life, there was worsening of respiratory distress along with increase in ventilator requirement. First, we thought it to be fresh onset sepsis, so antibiotics were upgraded. To our surprise, both the chest X-ray and 2D echocardiography shows marked increase in pericardial effusion, which is minimal on the day of admission. By this time, hypoalbuminemia was also corrected as we have ensured proper nutrition of the baby, but there were no other signs of heart failure as well. So, faced with this uncommon presentation of pericardial effusion in Down syndrome, we did a thorough literature review where only 24 cases of pericardial effusion with Down syndrome was found to be reported worldwide. According to literature, the cause of effusion in this case is transient abnormal myelopoiesis. The management modalities as suggested by literature are pericardial tapping under UHG guidance if respiratory and hemodynamic compromise is there, and alternative therapy option is steroids. As parents didn't give consent for a pericardiocentesis, so we started a short course of steroid after getting an informed consent. By day 4 of steroid therapy, we were quite encouraged by the clinical improvement the baby had. We also repeated the echocardiography that shows regression of the pericardial effusion, and we were able to wean him off ventilator. So pericardial effusion in Down syndrome, according to literature, is associated with transient abnormal myelopoiesis that causes release of cytokines into the pericardial cavity. To best of our knowledge, only 24 cases of Down syndrome with perinatal pericardial effusion has been reported worldwide. It can also be associated with hypothyroidism, viral infection, and other hematological malignancies. This is one of the case reports submitted by Falasco et al. Mentioning about a 14-day-old newborn baby with Down syndrome with transient abnormal myelopoiesis. They managed him with pericardiocentesis and also a low dose of cytarabine. In another case report of similar presentation, they also have treated him with a short course of steroids for the effusion. In a case series published in International Journal of Clinical Cardiology, mentioning about 2 cases of trisomy 21 with pericardial effusion due to transient abnormal myelopoiesis and hypothyroidism. So concluding my presentation, in newborn with Down syndrome, pericardial effusion is a rare presentation, and large effusion can cause respiratory and hemodynamic instability requiring pericardiocentesis under UHG guidance. An alternative modality of management is short course of steroid therapy. Thank you.
Now, Dr. Shruti will present.
Good afternoon, respected faculties and my colleagues. It is my honor today to discuss this patient who came to us with 2 coexisting conditions which are not very uncommonly seen individually in a pediatric unit, but not very commonly seen together. So this is the story of a 9-month-old female infant hailing from the tea garden community, developmentally normal and immunized as per age, who presented to us with the chief complaints of fever for 3 days, for which she was undergoing treatment at the district hospital, and abnormal jerky movements of the right side of the body, which started on the day of admission, for which she had been referred to our hospital. The fever was mild, continuous, insidious in onset, associated with refusal to feed, and not subsiding with medications. Multiple episodes of convulsions had started on the day 3 of illness, involving the right upper and lower limbs of the body, along with deviation of the angle of the mouth to the left side. There was no history of chills and rigor, inconsolable cry, cough, runny nose, yellowish discoloration of eyes and urine, and skin rashes. So when we got the patient on general examination, we found a febrile, dehydrated, lethargic, and tachycardic child with normal respiration, blood pressure, and oxygen saturation. Anthropometry revealed severe acute malnutrition. And so we went back to the history, and dietary history revealed certain red flags, such as delayed initiation of complementary feeding, incorrectly prepared formula, mixed feeding, as well as a grossly deficient diet. Nervous system examination revealed that the child was conscious but lethargic with a modified GCS score of 13 by 15. There was right-sided upper motor neuron type of facial nerve palsy with sparing of other cranial nerves. Motor system examination showed hypertonia in view of reduced range of motion on the right side with increased resistance to passive stretch. All the amyltison angles on the right side were abnormal, and deep tendon reflexes on the right side were brisk with right-sided ankle clonus. Touch, temperature, and pain sensations were intact, and other systemic examination was essentially normal. So we went ahead with the provisional diagnosis of acute onset right-sided hemiparesis with upper motor neuron type of right-sided facial palsy due to cerebrovascular accident, probably of ischemic origin in the cerebral cortex with coexisting severe acute malnutrition. On the first day of hospitalization, the child suffered from multiple episodes of right-sided focal seizures, which were controlled with multiple antiepileptics. The culture reports were sent and empirical antibiotic cover was instituted as per the unit policy. By day 2, the convulsions had been controlled and we started F75 starter diet along with other nutritional supplements. We were finally able to do the CT brain. And when we obtained the report, we were quite surprised to find a massive area of involvement. Hypodense areas were seen in the left fronto, parieto, and occipital lobes, suggestive of subacute infarct with hemorrhagic transformation. And that is when we started thinking in terms of internal carotid artery involvement. By this time, the other reports were at hand. Hematological parameters showed anemia, which was microcytic hypochromic with leukocytosis. The coagulation profile was essentially normal. Electrolytes did not reveal any abnormalities. CSF also did not show any abnormal findings. The HPLC, which was particularly important in our case because the child was from a community with high prevalence of sickle cell anemia. But for our patient, it was normal. By day 4, the child became playful, but she was unfortunately unable to move the right side of her body. The fever had now been controlled. The culture reports and the fever profile were obtained and they did not give us any additional information. Echocardiography ruled out congenital heart disease or any other structural heart disease, and gastric lavage was negative for acid-fast bacilli. On day 5, we were finally able to do the MRI brain, and at the same time, we continued conservative management and support. The MRI brain with angiography and venography also showed subacute infarct of the right cerebral hemisphere with hemorrhagic transformation and normal cerebral vessels. But here we face the challenge that our hospital, like many others, has a 1.5 Tesla MRI machine, whereas literature has suggested that it is the 3 Tesla MRI machine which is better for pediatric neuroimaging. So the child was enrolled under District Early Intervention Center in our hospital for physiotherapy and early stimulation. And after a period of satisfactory weight gain, the child was discharged and is currently doing well on regular follow-up. So we obtained the final diagnosis, acute onset, right-sided hemiparesis with upper motor neuron type of right-sided facial palsy due to cerebrovascular accident of ischemic origin in the cerebral cortex with hemorrhagic transformation, probably due to thrombosis following dehydration with coexisting severe acute malnutrition. But as clinicians, certain questions remained. Fever and stroke, how common are they together? Hemorrhagic transformation, why and how? Malnutrition and stroke, is there any association? Could there be some missing links? And what more can be offered in the management? On one hand, India is one of the largest global contributors of malnutrition, with the NFHS 5 cutting in extremely sorry figures. And on the other hand, pediatric ischemic stroke is a significant source of neurologic morbidity with numerous debilitating consequences. It poses certain unique challenges in diagnosis because of lack of clinical suspicion, diverse and non-pathognomonic presentation because the hallmark acute hemiparesis is common only in older pediatric patients. Seizures, particularly focal seizures, are the primary presenting symptom for younger children, which was also the point in our case. And a broad list of differentials, the so-called stroke mimics, adds to the complexity of diagnosis. That is why certain scales such as the PEDNIS, the Rosier, and the FAST has been suggested for use during emergency evaluation. Now, coming to the question, how common are fever and stroke together? The landmark International Pediatric Stroke Study has suggested certain risk factors for arterial ischemic stroke, of which dehydration, sepsis, and fever were present in our case. The vascular effects of infection in pediatric stroke study, the VIP study, also suggests that viral infections and recent vaccinations are responsible for higher occurrence of arterial ischemic stroke in children. When we wanted to look into the literature about why hemorrhagic transformation had happened in our patient, we came across this study from China, which had concluded that malnutrition risk was significantly associated with increased risk of hemorrhagic transformation. But this study included only adult patients, and whether the same is applicable to the pediatric population remains to be seen. But definitely, this is an area of interest that can be looked into. Since the workup did not give any definite clues, repeatedly we were wondering if we, as well as the parents, had missed some crucial piece of information in the history. So we did a thorough literature review, and we were quite surprised to find that there were multiple case reports, many case reports of trivial oropharyngeal trauma leading to massive cerebrovascular accidents and their neurologic consequences. As acknowledged by the scientific statement from the American Heart Association and the American Stroke Association, pediatric stroke diagnosis poses certain unique challenges, such as a prolonged median time from symptom onset to medical attention being around 1.7 to 21 hours, which was there in our case, median time to radiological confirmation being as long as 15 to 24 hours, which was also there in our case, delay in accessing MRI related to the need for sedation and anesthesia. This is something that we regularly face on a day-to-day basis, and delays of being greater in evenings and weekends. Pediatric stroke management is unique, and the guidelines are also there in place, but not very commonly known. So it is important that in the management of pediatric stroke, we need to follow evidences quite thoroughly. The class 1 recommendations suggest the control of fever, maintenance of normal oxygen levels, normal blood pressures, and normal serum glucose levels. Treatment of dehydration and anemia in children with stroke is a class 2 recommendation. And there are certain class 3 recommendations that there is no evidence for the use of supplemental oxygen in absence of hypoxia, or prophylactic administration of anti-epileptic medications in the absence of clinical or electrographic seizures. And hypothermia should not be used except in context of a clinical trial, because data regarding the safety and efficacy is not yet available. The million-dollar question, thrombolysis, which is the cornerstone of management of adult stroke cases. The evidence regarding thrombolytic therapy for childhood stroke is quite scarce. So it is the class 3 recommendation that unless there are additional published safety and efficacy data, TPA is not recommended for AIS outside of a trial. This is the class 3 level of evidence C. However, it is a class 2 recommendation that TPA may be used in selected cases of cortical venous sinus thrombosis, but the decision has to be taken on a case-to-case basis. The thrombolysis in pediatric stroke study, which was unfortunately abandoned midway, tried to offer potential criteria to safely utilize TPA in children, but these have not yet been widely accepted. Considering that the risk of recurrent stroke in older children is quite substantial, with more than 1 in 10 having another stroke within a year of diagnosis, and this risk being even higher in children with arteriopathies, it is important to take care of the future of the child after discharge. So it has been recommended that antiplatelet therapy with aspirin as the drug of choice at the dose of 3 to 5 milligrams per kg per day should be started and continued up for a minimum period of 2 years after ensuring adequate gastroprotection. Anticoagulation with low molecular weight heparin has certain specific indications like cardiac embolism, history of thrombosis, known cases of prothrombotic disorders, and severe genetic thrombophilias. Also, it is important to note that outside the setting of sickle cell disease, there have been no stroke prevention trials in children. So from this case, what we learned was that a high index of suspicion is necessary to rule out CVA in all cases of acute onset focal neurological deficit and focal seizures. Appropriate management of coexisting conditions and timely referral is of utmost importance to improve the final outcome. Strict monitoring of children at risk of CVA is necessary, and role of malnutrition in CVA could be an area of interest warranting further research. Thank you.
Chandra? Hello?
Yes, ma'am, we have completed
Yes,
the
ma'am.
presentations.
Are you going to say something? Are you going to say something?
Ma'am,
No, ma'am.
summarize. To summarize.
Oh. Okay, so now all the three students, they have presented the cases excellently, excellent talk, and the cases were also really interesting cases that they have told. I think a few of the panelists or the faculties will have some queries to be asked to the students. Anybody? Interesting cases? Yes.
Thank you very much for those three wonderful cases.
Yes.
Just one small comment on the last case.
Yes.
Madam, have you checked for the homocysteine levels in this child?
So that was actually planned, but it's not available in our hospital, and the patient was actually quite poor. So it was because of financial constraints, we were not able to do that, but we had that in mind.
Yeah, because the association of severe acute malnutrition is also associated with significant vitamin B12 and folic acid deficiencies, which may elevate the homocysteine levels quite significantly. And therefore, probably one may need to keep that in mind, because supplementation with B12 and folic acid will be very important to bring down the homocysteine levels there to prevent further strokes.
Thanks. Anybody else?
Ma'am, in the electrical injury, how do we exactly explain the quadriparesis? Because as you have explained, it's most of the time it is patchy insults, and how exactly we explain quadriparesis, because it should be at the cervical spine and the electrical injury.
Yeah, you would like to say?
Dr. Sharda?
Yeah.
Dr. Sharda?
Yes, ma'am. Ma'am, actually, ma'am, at that time, the quadriparesis improved with physiotherapy, but initially there was physiotherapy with increased DTRs and spasticity. Firstly, ma'am, there was the MRI, ma'am. The MRI showed normal study, but we have other literature that suggests that there is demyelination of the motor tracts, which can result in such type of presentation. So that is, ma'am, diffusion weighted imaging should be done for to get that result, ma'am. So that was not done for the patient. So that is, ma'am, in that way, this demyelination can, ma'am, have.
And also we had easy findings of
EEG findings were also present of diffuse encephalopathy.
And just one thing, what is the cause of fever in child with hemiplegia? What is the cause of fever? You did all the examination. Fever what was the cause of fever in that child? Was it the association with the neurological findings?
So the child was having only fever at the time of presentation, but when the child was admitted, we'd also done a chest X-ray where we got some patchy pneumonitis. So it might have been a coexisting ARI that had caused the fever.
Right. And in this Down syndrome with pericardial effusion, all the reports suggest you have been given steroids only. Steroids have been given to treat that. So it means the mechanism is something, the etiology is something immunological.
Yes, sir.
Or steroid has been given only for the compressive effect of the effusion, just to decrease the edema part or the swelling part.
No, sir. For the regression of the effusion, the indication of steroid is there, and also cytokine. It reduces the cytokine release, and sir, use of cytarabine also has been advised according to the literature.
So it is like the pericardial effusion is because of the cytokines which are released from the leukocytes in TEM. And with steroid, there is the reduction in formation of the cytokines. That is how the fluid regression is there.
And in other reports also, the treatment has been steroids only, or what?
Yeah,
The cause was different.
Yeah.
Steroids and cytarabine has been advised.
Some of them have gone for pericardiocentesis also when there is respiratory compromise, but otherwise, many of them have mentioned about steroids.
Thank you. Very nice cases.
Thank you, sir.
Aarti ma'am, request your closing remarks, then we can go ahead with the other.
Okay. Now, all the three cases were presented excellently. All the three students, they have presented excellently, and the cases were also very nice. Very nice. And credit goes to the teachers also. The students, they have presented, it's all right, but the backbone initially, the how to present and where to give stress and all those things come from the teachers. So, so all credit goes to Dr. Rita and her colleagues in the department, faculty in the department. Now, regarding your Arpita's talk and Dr. Okifa's talk, they were really excellent talk. Dr. Priya, do you agree? Yes, it's really, really,
Yes, ma'am.
Definitely, ma'am, definitely.
Yes, really excellent talk. And they have talked so nicely in that stipulated time of 15 minutes. Everything she has covered, Dr. Arpita has covered RPGN in details. So it's really nice. I just want to ask one thing to Arpita. The investigations that you have done, all the investigations were done in AMC, or you have sent the investigations to outside lab, the electron microscope and all
Yeah,
those?
madam, ANCA levels are not done in-house, but ANA and DSDNA are done. Again, complement again, we have to send outside. And as far as renal biopsy, only light microscopy is done here. Immunofluorescence and electron microscopy is done outside.
Okay, so where do you send?
We send to Lal Path Lab usually, the IF and the electron
So
microscopy.
it takes how many
Private
days?
lab.
7 days? 7 days time?
The immunofluorescence comes in 7 to 10 days, but electron microscopy around 15 days, 20 days.
Okay.
Yeah.
Okay. So even with this, you have done so much of investigations to diagnose the case. It is important because though it is a rare, RPGN is though it is rare, but even if you can diagnose early, and unless you diagnose it, usually it is fatal. So to diagnose it early is very important for all of us. So I think that's all, Dr. Priya. I think it's a very nice interactions, and I request the IIP, the central IIP, to have more of such kind of interactions in the medical colleges, and so that the teachers and students, both of them can participate. It will be enriching for all of us. Thank you. Thank you for giving me this opportunity.
Thank you so much, ma'am, for very well moderating the whole session. As the PG student said, knowledge is important, but knowledge without action is meaningless. That is a great learning today, I think. I request our Professor Dr. Pramod Jog, sir, for your remarks.
Oh, thank you, Priya. And I agree with you what you said at the end, that knowledge without action is of no use. So it was another nostalgic afternoon today with Dr. Aarti Deka chairing this session and telling us about this most loved medical college in Assam in this charming Dibrugarh. And Dr. Rita Bora, the HOD, she gave us the origin of this word Dibrugarh, and she told us that it's from this river Diburu. And I knew that it's known for oil and natural gas, and it's known as the tea city of India. So that is very important. And it has crossed almost 75 glorious years from the year of our independence. And I know that it's the industrial hub of the Northeast. And the academic feast was really great, with Dr. Arpita telling us about this rapidly progressive glomerulonephritis. I remember my teacher used to tell us that this glomerulus is nothing but, the endothelium of the capillaries, then the glomerular basement membrane, and the epithelium of the, Bowman's capsule. So together when they come, it produces problems, and the problems could be at three levels at all these, either the endothelium or the basement membrane or the epithelium. And that was, of course, related to various aspects of the glomerulus. And we usually think of acute glomerulonephritis, but when the acute glomerulonephritis comes along with worsening glomerular filtration rate and those glomerular crescents, then we have to think of this rapidly progressive, disease, where there is progressive loss of the kidney function, and it's over a very short period. And she elaborated it very well with those two cases. The first one, that was the 11-year-old girl with, I think, hypertension and the fluid overload. And then she also mentioned about the causes, the renal causes related to the glomerulus or the tubulointerstitial or the vascular, and the systemic causes like SLE. And the description about the complement levels and the relation with the low and the normal complement levels, the renal biopsy and the immunofluorescence, and all the workup. So in any case of hematuria and oliguria and hypertension where we suspect AGN, we must go a bit beyond. And she also told us about the place of immunosuppression. And the other child, the 9-year-old girl with systemic vasculitis, which turned out to be IgA vasculitis with rapidly progressive glomerulonephritis, and was again subjected to renal biopsy and peritoneal dialysis, and then pulse methylprednisolone and oral cyclophosphamide and methyl mycophenolate was given. I was rather reminded of the postgraduate days when our teachers also used to ask us the mechanism of crescent formation and what constitutes the crescents. And we used to tell him that is the fibrin and the parietal epithelial cells. And as I told you, the anti-glomerular basement membrane disease, the immune complex glomerulonephritis, where we used to say that the glomerulus is the victim of its own filtration mechanism. And that's the basic problem. And all those types that she mentioned with electron microscopic findings and the syndromes associated with this and the diagnostic evaluation and CANCA and PANCA, okay, and the principles of therapy and the importance of monitoring so that the child doesn't land up in end-stage renal disease. And I was glad that she concluded saying that acute glomerulonephritis may complicate into all these problems, and one has to differentiate it from the hemolytic uremic syndrome, and intensive immunosuppression may be required. So it was a different kind of a presentation, and glad that she took it up. And the three cases were really the postgraduate cases, with Sharda Mujumdar telling us about that electrocuted child with shock who fought for a month and then developed neurologic sequelae. And we, after a long time, I had learned this electrocution only in the forensic medicine department and then in pediatrics. So there was, discussion about the cardiac arrhythmias, acute kidney injury, loss of consciousness, seizures, and those kissing burns and fractures, all that related to electrocution. But I must say that first one must put off the electrical source. Otherwise, if you try to save the child, you may yourself get electrocuted. Anyway, apart from that, we must remember the law of safety of electricity, which she told, the periodic electrical audit in our clinics as well as in schools and other workplaces, and the importance of parental information about the electrical safety and the safety measures. So that was a different topic again. And then Elora told about this uncommon cardiac problem in the Down syndrome, where there is pericardial effusion because of cytokine release related to that transient abnormal myelopoiesis. And I got one more point to be asked to the postgraduates tomorrow at the rounds, when I would ask them as to what are the problems, cardiac problems in Downs. And I will definitely take the credit of telling them one more point about this, pericardial effusion. And then Shruti, she told us about the infantile stroke and the child with abnormal jerky movements with fever and right upper motor neuron facial palsy, and brought out some important issues as to how common fever and stroke exist together, the hemorrhagic transformation in the malnourished children. And then Jagdish told us to remember about the folic acid and the B12, supplementation in these cases. And then, of course, the trivial trauma leading to the stroke. I remember when we used to doze off in the classroom with the pencil in the hand, the teacher used to tell us, see, beware of that pencil. It may touch the area of the tonsils. And in children also this can happen. If the child is dozing in the classroom, that may initiate the damage to the arteries. And then, of course, she nicely elaborated the challenges in the pediatric stroke diagnosis and management, including the thrombolytic therapy. And I must give special credit to Dr. Akifa Islam, who presented the research publications. And what an array of research publications related to maternal anemia, the timing of the umbilical cord clamping and the feed intolerance, and that NEC and the peripheral vessel extension transfusion being better than the central veins, and the transient hypoglycemia, screening for G6PD, and anthrax with bullous lesions, and so on. So I must congratulate her. And I am definitely tempted to read Dr. Gyanendra Sharma's books because I have not read them. But when Dr. Shantanu told, then I am now tempted. Anyway, I must say that Northeast is the place of the gods in the Vastu Shastra. Because I know this because my wife had, pressurized me to shift the place of the gods from one place to the Northeast in my house. And Northeast, that's why I always will be blessed by the gods. And I wish all the listeners and our colleagues from Assam happy Rongali Bihu, the spring festival. Thank you.
Yes. Thank you, sir.
Thank you so much for your ever ready, crisp and clear summarizing the whole session, sir. I think it's that itself is a talent and an art which you are blessed with, and we are blessed to hear that. Thank you so much, Dr. Pramod Jog, sir.
There were no yogisms today.
Yogisms were less.
Yes, sir.
Okay. Thank you so much, sir. I now request our East Zone coordinator, Dr. Kalpana ma'am, to present the vote of thanks.
Thank you, Dr. Priya. First, I would like to say thank you, Dr. Pramod Jog sir, for nice compilation, and everything is remember the name and the topics and all those ifs and buts and hooks and nooks of the presentations. So thank you, sir. And my sincere thanks to the President, Dr. Vasibhajan, our HSG, Dr. Parik sir, Treasurer, Dr. Atanu, and our advisor of this academic institution, Dr. Chinappa sir, and all the coordinators, the Vice Presidents of the all zones, especially East Zone. He has done wonderful job to coordinate everything nicely, more than me, Dr. Shantanu. And I must thank the chief guest, Dr. Jane Sharma sir, today's chairperson, Dr. Arati Dekas ma'am, HOD of the Assam Medical College, Dr. Rita Bora, and her entire team for presenting such a wonderful sessions and keynote and the history of the medical colleges and the 3 cases. My sincere thanks to all the students, attendees, JRs who has joined from the college, and all the attendees all over India. My sincere thanks to Priya. She is a pivotal role for this academic institution. She's always eager to help and give guidance how to conduct, her way to communicate and all. So thank you, Dr. Priya. And last but not the least, thanks for the providing DIB platform for having wonderful program all over India. Thank you all.
Thank you, ma'am. The next program
Thank
is
you
on
so much.
19th April. The participant will be GR Medical College, Gwalior from the Central Zone. I request all of you to join again on 19th April. So thank you once again to the whole faculty, whole department of pediatrics from Assam Medical College. Thanks to Rita Bora ma'am. Thank you
so much,
sir, Dr. Jayan Sharma sir, and Chairperson Dr. Aarti ma'am. Thank you all.
Thank you so much.
Thank you so much. Thank you, ma'am.
Bye.
Thank you. Bye.
Thank you.
Thank you.